Dr. Colleen Vernick is a distinguished neuroanesthesiologist with over 20 years of experience at Jefferson University Hospital. She earned her neuroscience degree from the University of Pennsylvania and her medical degree at the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine. She trained in anesthesiology at Penn and has since specialized in managing complex brain and spinal surgeries. Dr. Vernick has served as the Director of Neurosurgical Anesthesiology for over a decade and is currently the Chief of Anesthesiology at Jefferson Hospital for Neurosciences. Her dedication to patient care, safety, and medical education continues to advance the field and mentor future anesthesiologists. She'll be speaking on "So You're Telling Me I'm Going to Be Awake for My Brain Surgery." Please join me in welcoming Dr. Vernick.
So today we're going to be talking about awake craniotomies. These are cases where you feel like you are walking on eggshells the whole time, and afterwards, if it's a successful procedure, you feel really good about yourself. However, it's not always successful, so we'll get into that. I just included a little synopsis of a patient who had an awake craniotomy and was interviewed afterwards. So if anyone wants to look at that when these are posted after the conference, go ahead. Not all experiences are terrible, and most are pretty good. So the awake craniotomy, why do we perform them? Well, we do that when the surgeon, didn't come up, is operating on or around eloquent areas of the brain. And by eloquent, I mean areas of the brain that are responsible for speech, motor activity, cognitive function, sensory. We don't necessarily have to do it for sensory and motors anymore because we have good neuromonitoring for that. But for speech and cognitive function, we really do need to have the patient awake in certain scenarios. Also, sometimes we do ECOG, which is electrocorticography, and we do that sometimes asleep, sometimes awake. But if they are operating on the dominant hemisphere, which for 90 to 95% of us, that is the left hemisphere, then we do the electrocorticography awake. So what is electrocorticography? It's something they do during craniotomy where electrodes are placed directly on top of the cortical surface, and they do real-time recordings, and they look for epileptiform spikes or seizure activity, and this allows for a tailored resection of the seizure focus, and this way they can remove as much tissue as possible without leading to deficits, cognitive or speech deficits in these patients. They also do motor function when they're awake as well, sometimes when they're asleep. The important thing for us to remember is when the surgeons are doing ECOG, we want to avoid medications that will raise the seizure threshold. So we want the patients to have their seizures. So I would not pre-medicate with a benzodiazepam in this instance. So now we know who needs an awake craniotomy, but really does it affect outcomes? Because does it make a difference? So this first study, and again, these studies are not perfect. The data is really insufficient. It's hard to do studies on these cases. There are lots of case reports and whatnot. But this first study looks at a cohort of 575 patients. And these patients they have gliomas. And they put them into two different groups. The first group, awake craniotomy group. The second group was a sleep craniotomy for resection of tumor. And they wanted to look at how it affected outcomes in these patients. So basically 231 of the patients were in the awake craniotomy group, and really only 72 of the patients were included in the asleep group because they only wanted patients who were having surgery on eloquent parts of the brain, right, affecting cognitive function and speech and whatnot. The other patients were the tumor was in the non-dominant hemisphere. So really, when they looked at outcomes, of course, if you're doing asleep versus awake in these patients and they're operating in at-risk areas of the brain, you are going to find a difference in outcomes. So they found a higher gross total resection rate meaning more tumor was resected in the awake group. That makes sense because the surgeons are comfortable now removing more tumor because they're getting real-time functional exams. There were fewer permanent neurologic deficits in the awake group versus the asleep group. So these are permanent deficits. So when you look at the next data point, you'll see a new onset. Well, new onset doesn't always mean permanent. So when you look at the new onset deficits, it was 3.3% versus 58%. Sorry, there's a typo there. I thought I switched my slides yesterday. This is an old one. But so basically, new onset does not mean permanent. So frequently when they're operating and there's edema in the area, patients will wake up with deficits in at-risk areas. The next study was looking at, this is a multi-center comparison of awake craniotomy versus general anesthesia in patients with high-grade gliomas. So basically, they had a large group of patients, and once the certain patients were excluded, we were down to about 900 patients. 80% of those patients qualified for a sleep craniotomy, and 20% of those patients qualified for an awake craniotomy. And this, again, was whether or not the tumor was in a dominant hemisphere and whether it was affecting eloquent areas in the brain. And what they were looking at was progression-free survival, meaning the time that it took for them to see a change on either a CAT scan, MRI, or a change in patient symptoms versus overall survival. So when we look at this slide and we look at these graphs, we see a steep decline in progression-free survival, in actually and overall survival, but especially progression-free survival. And when they compared awake craniotomy versus asleep craniotomy, there was no difference. There was no statistical significant difference in asleep versus awake. So the patients had progression at 0.54 years for awake craniotomy and 0.53 years for asleep craniotomy. When we look at overall survival, there actually was a difference. There was a longer survival in the patient's median survival rate in the patients who underwent awake craniotomy, and that median survival was about 20 months versus 14.4 months for those that underwent an asleep craniotomy. So really, there's speculation, why is that? Did they get a better resection? Was the surgeon more comfortable resecting more tissue in these patients? There's speculation, could it be because the patients had scalp blocks? And we do know that if you do a scalp block for a craniotomy, the patients have a lower stress response post-op, and lower cortisol levels have been drawn on those patients in comparison to those who had an asleep craniotomy. So we're not exactly sure why this data showed this, but it did. So for awake craniotomy, there are contraindications. That being said, patients who have an indication for an awake craniotomy usually need to have an awake craniotomy. That is to their benefit. So even if they don't have longevity, you want them to have a good quality of life for the remainder of their lives. So the contraindication, the big one, is the patient cannot cooperate. So this could be due to several reasons: developmental delay, lack of maturity, severe anxiety, an exaggerated response to pain, or a significant communication barrier. So we frequently will have patients who really have an indication for an awake craniotomy, but they already have deficits, speech deficits. So what I do is I see the patients in the preoperative area. I don't usually get to see them, maybe the night before, and I give them a simple task. They've already been evaluated by the neurologist and the neurosurgeon, and I say, can you just recite the ABCs for me? And if they can't recite the ABCs, they really can't have an awake craniotomy. They're not going to be able to do functional cortical mapping, right? They're not going to be able to speak, look at pictures. It's just not going to work out well. So we had to do a couple under general anesthesia for that reason. If the patient speaks another language, you really don't want to use a translator on the phone. So in the past, I had a patient that only spoke Cantonese, and I just went through our resident lists and found a CA1, a new CA1 who spoke Cantonese, and I said, it's your lucky day, you're going to do an awake craniotomy. So CA3s weren't that happy, but the CA1 was happy. Relative contraindications, obesity and obstructive sleep apnea. That being said, we've done them on patients that weigh 500 pounds. In those cases, you want to be careful. You'll probably do an awake rather than a sleep awake, which we will talk about shortly. Patients with a known difficult airway. Again, you can lose the airway anytime during an awake craniotomy. I recently had to do an awake craniotomy on a patient with subglottic stenosis, and I was working with a surgeon who preferred a sleep-awake technique, but I really did not want to manipulate that airway and potentially cause any edema and lose the airway, so we just did it under sedation and very gentle sedation. Someone has a chronic cough, they're not going to be able to sit in pins and not cough during the procedure, so whatever's causing it needs to be treated ahead of time. And then highly vascular lesions where there is an anticipated large blood loss, you really want to consider not doing that awake. I've had unanticipated large blood loss during awake craniotomy, and that's not pleasant because you do have to secure the airway relatively quickly in pins in a lateral, sloppy lateral position under the drapes, while you're also trying to treat hypotension, get blood, and that's when you call for help in the room. The goals for the awake craniotomy, it's pretty simple. You want the patient to be comfortable and you want them to be able to cooperate. The whole goal is this patient can have a resection that's tailored. They can get as much tumor out as possible without this patient losing any function, right? You want this patient to have a good quality of life. You want to avoid paradoxical agitation, so you have to consider what medications we use can cause that. If you're doing an asleep-awake technique, you really have to be aware of emergence delirium, and we'll talk about that also. I've used TIVA now if I'm doing a sleep-awake because there's less emergence delirium than there is with inhaled anesthetics. And during the sedation part, if you're doing awake, you have to avoid oversedation. You don't want to lose the airway. You don't want hypercarbia that, as we know, increases cerebral blood flow, makes for poor surgical conditions, and a cranky surgeon. And, of course, maintain the airway throughout. So you have to carefully select patients for these procedures, but really based on the disease state, these patients are already selected for you. So the next step is you have to counsel these patients. So you have to tell them what's going to happen every step along the way to decrease their anxiety so there aren't hopefully any surprises. And you have to be prepared to communicate with the patient throughout the procedure. These patients have to have scalp blocks and they have to be done right. If they're in pain, you're done. They're not going to tolerate anything during the awake procedure, and they're not going to be able to work with you and the neuro team. When doing a scalp block, do your calculations ahead of time. Determine how much you need, how much you can use for each of the nerves, and then save some extra in case the surgeon needs to supplement intra-op. And then be prepared for the uncomfortable portions of the procedure, especially if you're doing awake, such as pinning, craniotomy, and manipulation of the dura. Monitoring standard ASA plus or minus A-line. I still use A-lines. I'm very comfortable with it because I want to be able to check electrolytes. We still use pretty large doses of mannitol, and we basically cause a lot of electrolyte abnormalities. I know in Europe they're not using A-lines standard all the time for these awake craniotomies anymore. Obviously, you need to monitor end-tidal CO2 and always have suction oxygen and a way to salvage the airway readily available because it happens when you least expect it. Positioning. So I can't stress this enough. As an anesthesiologist, you really need to participate in patient positioning. Let me go to this next slide here. So frequently, these, in 90 to 95% of these, they're operating in the left hemisphere. So the surgeon needs to have access to the left side of the brain. And, they're inclined to just rotate the head like this. Well, imagine trying to ventilate that patient and salvage the airway if they're not in a good intubating position. So I always participate in positioning, and I hold the head and make sure the patient's in a good sniffing position. So usually the patient is in I call it sloppy lateral position, sometimes fully lateral position. But the key is to make sure the head and neck are aligned and not rotated. And so that if you have to secure the airway in pins under the drapes, it's not quite as difficult, although it's never really easy. Make sure all pressure points are padded, because again, patients will complain of being uncomfortable. And I tell patients ahead of time, if you need to stretch an arm, a leg, or a limb, whatnot, let me know. I will help you do it. I will let the surgeon know we are moving an arm or a leg, because patients do get uncomfortable, especially for very prolonged procedures. The other thing you want to do is you don't want to create an oxygen reservoir underneath the drapes. So you want to use some sort of contraption. We use a Mayfield stand to basically, you also have to have access to the patient's head, and they need to be able to talk to you, communicate with you and the neurology team. But you also don't want a big oxygen reservoir under those drapes. So I open it up, if we're sloppy lateral, at the head, and I open it up all the way down the side of the patient and put the drapes on a pole so that hopefully we don't have a large oxygen reservoir. So ways to do this, asleep, awake, asleep technique, and then asleep, awake, awake, which is very common, and then awake, awake, awake. And awake, 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 we will just call it MAC for now, for our purposes today. So what are the benefits of MAC? There's a lower failure rate for the awake craniotomy. So it's 1% versus 4% in the asleep awake. And that's probably due to our anesthetics and emergence delirium and increased nausea vomiting. What's also interesting, though, is they found that there is a shorter procedure time. And I believe that this is due to the attending surgeon being present throughout the procedure, except for closure. They're there, they are ready to go, the neurology team comes in. It's all very time sensitive, and everyone wants to get done as quickly as possible, which doesn't always happen, but interesting though, and these two are not statistically significant, is shorter hospital stay. About 4 days for the awake craniotomy versus 6.75 days for the asleep awake craniotomy, and a lower incidence of nausea vomiting, which is really no surprise in the awake craniotomy versus the asleep awake craniotomy. Although again, these two, length of stay and nausea vomiting, have not been found to be statistically significant, which surprises me. Also not surprising, one of the benefits of the asleep-awake technique is the lower incidence of intraoperative seizures. And that is probably due to the anesthetics used. Most of the asleep-awakes are now under, general anesthesia with a propofol drip, so less likely to have seizures. So as far as failure, we said 1% in the awake-awake, 4% in the asleep-awake technique. The overall is about a 3% failure rate. And what is the cause? The biggest cause is lack of cooperation. Sometimes patients will warn you, I'm not going to tolerate this, I can't do it, I won't do this. You talk to the surgeon and you said, this patient is telling me they will not tolerate the awake portion and that they're going to freak out. And you do your best to have them not freak out, and they freak out, and then you have to go back to sleep. Intraoperative seizures, 13%. In my practice, I haven't found that seizures, actually just once, because the patient became post-ictal, that neurology was no longer able to do the cortical mapping. So it can cause a failure. Drowsiness or oversedation, that's something that is typically on us. Again, in that morbidly obese patient who was 500 pounds, I mean, that patient just got dexmedetomidine and basically nothing else. Acute neurologic deterioration, that can happen for multiple reasons, and then the patient becomes uncooperative, and then you may have to secure the airway. And then there were other causes that weren't really described in this study, probably multifactorial. Comparison, again, we already talked about the nausea, vomiting, length of stay, not statistically significant, which is surprising to me, but intraoperative seizures. Well, why do they have seizures? Why are they at higher risk? Well, you know, a good portion of these patients are coming in with seizures. So a lot of these patients are having resection of a seizure focus, so they're very high risk. The tumor patients, a lot of these tumor patients come in and their first sign of this brain tumor is they have a seizure at home. So they're all at pretty high increased risk. When we talked about the MAC versus general asleep-awake versus awake-awake, maybe, you know, again, propofol probably contributes to the decrease in incidence of seizures in the asleep-awake group. And there is some speculation that dexmedetomidine could potentially contribute to the higher rate in the awake-awake craniotomies because they found in animals that it reduced the seizure threshold. Not necessarily proven in humans at this point in time, so I'm not sure what to make of that. Most of these seizures can be treated with just cold saline directly on the brain, and that usually works very, very well. When it doesn't work well, you may have to add an additional anticonvulsant. The nice part is you typically have the patient's neurologist in the room. They know the patients well. They know what the patients are taking, and if you have to add another agent, they can make a recommendation, and you really want something that's not going to cause sedation or affect the cortical mapping. We talked about the benefits, a little bit of the asleep-awake. So the first one was the lower incidence of seizures, but also you can better control ventilation. So when I do an asleep-awake technique, it's usually for patients who have brain tumors, and you don't want the CO2 to get very high. So for those patients, you can control the ventilation. I usually use an LMA, and I put them on pressure control, a low pressure, but turn the rate up so that the CO2 stays at a reasonable level. And then also the patients are asleep for the painful parts of the procedure, which is nice for the patients. The downside is increased risk of emergence delirium. Scalp block, I'm not going to go over, but there are 7 nerves that you have to block. Usually we use bupivacaine, 0.25% to 0.5%, typically with epi. It lasts longer, it increases the amount you can use. They usually also have to supplement at the pin sites and sometimes at the dura. So if you do your calculations, you don't want to use it all up front just in case you have to supplement later on, and also depends on how long the procedure is. So for the asleep-awake technique, you can do an LMA, you can do a natural airway. Some centers will do an endotracheal tube and squirt lidocaine down the tube. I used to, 20 years ago, I would use inhaled agent. Now, years ago, I switched over to a TIVA because the patients are much less likely to experience emergence delirium. I typically also add dexmedetomidine to my anesthetic regimen because, especially for the younger seizure patients who are at higher risk for emergence delirium, some centers are using remimazolam, so if anyone is using that, I'd love to hear from you afterwards. I don't believe we have it yet. I haven't used it. I would probably trial it in other cases before I started using it for awake craniotomies, but I'm really curious to know if anyone's using it and how well it works. Again, I try to avoid inhaled anesthetics for this. And I do like being able to control ventilation for some of the larger brain tumors. Again, we talked about the benefit of performing the painful parts under general anesthesia. Before we wake them up, we always prophylax them for nausea and vomiting, usually with a steroid and Zofran. And then I do like the antiemetic effects of the propofol drip as well. You have to be right there in front of the patient and ready to communicate with them upon emergence so that they don't get nervous and they'll just see, all of the blue drapes. They don't see their surgeon. They have met you. Neurology is usually in the room and they know their neurologist, but you want to be right there and make sure everything's fine. Make sure the nasal cannula is already on and ready to go so that you can switch to monitoring end tidal through nasal cannula. During stage 2, the awake part, this is when they do the neuromapping plus or minus ECOG. The patient has to be awake and cooperative, so I will either maintain comfort with nothing if the patient's perfectly comfortable and has a good block in place, or a very low dose of dexmedetomidine. I'm talking 0.1, maybe 0.2 at that point. And if they're a little uncomfortable with positioning or the Foley is bothering them, then I might do a low dose of remifentanil, but I'm talking like 0.02, 0.03, very low, just to give them a little bit of comfort. And then the biggest complaint that I get when it's going well is that the patients are thirsty. Because we frequently use mannitol for these cases. So I always ask the nurses in the room, I can't leave at this point, but I ask them to bring in a cup of ice water, and I use a swab, and I just swab their lips, so it makes it easier for the patients to speak because their mouths are so dry at that point. Most patients try to take advantage, tell me they need more, and they start trying to slurp it. I'm like, all right, we don't need any nausea vomiting right now. But I think they do appreciate it, and we kind of discuss that ahead of time, and now the nurses know they like to go get it, like before we wake up. For closure, now some institutions will routinely go back to sleep. They'll put an LMA back in or whatnot. I find that these patients, if they have the appropriate block in place, they are just so exhausted that you can just do some sedation. And typically, I just turn up the dexmedetomidine, maybe add now a little bit of opioid for comfort for when it's all finished. And most patients just close their eyes and go to sleep. It's rare that you have to add something else. Some institutions prefer just at this point to add a propofol drip with or without a natural airway, maybe an LMA. But I just find if I just turn the sedation back on, they just fall asleep because patients get very exhausted. Again, we've discussed this. So if we're just doing a wake-awake technique, which is really my preference, you avoid emergence delirium. And I'm going to go over a case with you at the end of this. And there are also minimal effects on ECOG, on any of the cortical mapping. So you really take any of that interference out of the picture. I've already said I use dexmedetomidine pretty routinely. It's a great medication for the awake craniotomy. I was so happy when we got that on formulary in 2009. I remember because that's the year my son was born, and I was very excited that we got it. But it's a great sedative, analgesic, anxiolytic, and it really, at the doses we use, does not cause respiratory depression. It mimics general sleep. It's a great medication for the awake craniotomy if you don't want your patients to get disinhibited. And I find with the propofol, if you're in between light sedation and general anesthesia, I find patients just tend to get very disinhibited, and these patients are in pins, and you really want them to get through the surgery and have a successful resection of their tumor. Again, dexmedetomidine plus or minus remimazolam. I haven't used it. I'd like to have some experience with it at some point. You want to avoid oversedation. continuous verbal interaction. If I am doing awake-awake, I will lighten the sedation for positioning to make sure the patient's comfortable. So make sure everything is padded well, and that they're in as comfortable a position as possible, especially if we're anticipating a prolonged procedure. Obviously, you want to maintain spontaneous breathing throughout. The one thing I have found is the Foley placement is very stimulating for these patients. So I frequently have them on Dex and a little bit of Remy, and I will test their response to propofol right before they place the Foley. So I always make sure I'm in the room, because with that sedation going, if I give like 2 cc's of propofol, a lot of the patients become apneic. It's very temporary. It only lasts a couple of minutes, but I'm always ready with a mask. So either myself or the resident is at the head of the bed with a mask ready to go just for Foley placement. And then I can see what their response is to a low dose of propofol. Sometimes the elderly patients might get a little disinhibited. So I just use that as my test dose, and I do that routinely now. So I have a case. I had a 21-year-old male for a left frontotemporal craniotomy for resection of a seizure focus. Past medical history of intractable epilepsy, otherwise very healthy, normal BMI, male and potty 2. He had undergone 2 craniotomies in the past. And his anesthetic history, he had severe emergence delirium. So the surgeon calls me the day before, and actually several days before. This surgeon's very good about giving me a heads up. And he tells me about this patient's very severe emergence delirium. And I said, okay, well, we will use the awake-awake technique for this patient. He sounds like a perfect candidate for it. We'll avoid emergence delirium altogether. But then the surgeon says to me, he's like, well, I just want you to know this is going to be a very long exposure, like a few hours. By a few hours, he actually meant 4 hours for exposure, because he was anticipating a lot of dural scar tissue. And he was not kidding. So I said, okay, well, then we'll do an asleep-awake technique, because it sounds like this patient won't tolerate awake-awake. And the surgeon was like, absolutely not. This patient will come out of anesthesia swinging. He will punch me. He will pull himself out of pins. I know this patient. Trust me. So I'm like, okay, well, what are we going to do in this situation? There's no good answer. So I said, all right, fine. We will do our best, and I'll do the awake-awake technique. If it doesn't work, we'll have to secure the airway while you're doing your resection. I'll add dexmedetomidine to the regimen to try to help with emergence delirium if we have to go that route. Anyway, this patient did so unexpectedly well with a dexmedetomidine drip. I added a little bit of Remy for, painful parts of the procedure. This case, guess how long this procedure took? 13 hours. 13 hours. This patient tolerated it beautifully. His only complaint was thirst. He maintained a patent airway throughout. Now, he wasn't obese, so that was great. That was a definite bonus. He did all of the speech mapping, all of the testing. He did beautifully, and this was about 10 years ago. It was before we had Epic, and he's still seizure-free, so that was great. And that's the only time a surgeon came and found me afterwards, and I actually got a fist pump from the surgeon. It's like, great. However, that's a successful case. It's not always peaches and cream. I've had my share of humbling experiences with these awake craniotomies. So things do go wrong. First is nausea vomiting. We know that happens whether you do a sleep-awake or awake-awake. Well, my worst experience with this was during an asleep-awake craniotomy, and the patient just started desatting with the LMA in, and I couldn't figure out why. I bronched him through the LMA under the drapes, and And he had this like coffee ground emesis. So I said, all right, we have to stop. You're going to have to close the head. We're going to have to intubate. And I dropped an OG tube afterwards, and I got out 500 cc's of coffee ground emesis. So the patient actually ended up doing fine. He came back another day, and he did fine. But that was very humbling because I couldn't really figure out why he was desetting while he was aspirating. Seizures. I've had many patients have seizures during their awake craniotomies. Usually the cold saline works. Sometimes it doesn't. One patient, anytime they put electrode on a certain part, her arm would go flying up. So I told her, I'm just going to tape your arm down just for, a little while. And the patient was agreeable to it. Large blood loss, unanticipated. That's not great either. I recently had a surgeon say to me, oh, I just hit a branch off the MCA. I'm going to need you to secure the airway. And I said, I'll just throw the LMA back in because now we have to get blood products. We have things to do. He's like, no, I really need you to get the CO2 pretty low because I can't see anything that I'm doing. So that was very unpleasant, but the patient, they were almost finished their mapping and resection anyway, so the patient ended up doing fine, but it's always an uncomfortable experience. We tried to do a glide scope, but we weren't successful, so just did a fiber optic under the drapes, which is usually my go-to in these situations, because you're kind of not in a good position because the surgeons are at the head. It's unpleasant, but doable. And then, again, securing the airway under the drapes, lateral position, head in pins. Hopefully you're in a good sniffing position, but it's not perfect. And then I one time had a patient, she was pretty funny. She started answering all of the questions in Spanish just to kind of mess with the team, and she's laughing, and we're like, okay, that's great, but we really need to know if you understand like this picture. I don't know how to say dog in Spanish, so like, what is this? Anyway, she did well. She eventually decided to participate in English where we all understood the language, and that was that. So thank you. That's all I have.
Thank you. And we'll ask Dr. Abedi to come up as well and field some questions, if that's okay, if you guys don't mind having a seat. And Darren, I'm not sure if these are on. Well, thanks to our panel today. We lost Dr. Grenda, but have Dr. Abedi and Dr. Vernick here. Any questions so far from the audience on any of these topics? Yes, Dr. Hepney, go on.
This is for Dr. Abedi. You said hemodynamics is very important for a lot of what you do. Do you need to put inlays in these people then?
Yeah, so that seems to be a point of contention, and the SNAC guidelines say that it shouldn't interrupt the timing of the procedure. So if you have to stop the procedure or you have difficulty doing it, a lot of times there's the option to slave off the femoral sheath without interrupting the procedure. And you can also use the radial A-line off the slave off of that sheath also, but then when they start to intervene, you'll lose the blood pressure, which is kind of an important point. So you can use non-invasive blood pressure cuff, and they actually recommend it every 2.5 to 3 minutes.
So they already have the lines in. I don't do these all the time. So they have a line either.
No, so they usually obtain either radial or femoral access in order to get up to the cerebral vasculature.
We also looked at something on OD, and I didn't see it. The lady just came over. It's like a pulse ox, but
It will do a trace. It almost looks like an arterial line. We haven't. I think cardiac has it. Maybe I don't remember what it's called, but
I've called it different things. It was a Vigileo when I was a resident, but I don't know what we call it
But you
here.
need it.
But it's a finger cuff, non-invasive finger cuff.
it's non-invasive.
Yeah.
We're about to study that in the INR suite, so
Excellent.
yeah.
Yeah, the NextFin, I think, is a brand, and FlowTrack has one as well, I believe.
Yeah, it's the ClearSight is one of the brands. That's what we use in these situations where I'm time to put an A-line in, gives you continuous monitoring. Have you ever experienced a VAE in your weight cranies?
Not in an awake cranie. Asleep cranies, yes, but never in an awake cranie. So
And have you ever used a REMI PCA for your weight?
I have not. Have you?
Yes. Yep,
How is it?
find it very beneficial. This is why it gives the patient the idea of they have control of something in this very uncontrolled environment. We use it in our DBS cases and seem to have fairly good luck with it and good patient satisfaction.
I think I'll give that a try. I like it.
So we use a concentration of 20 mics per ml, but dilute it down, and then it's 1 cc every 3 minutes with no base.
Is that in conjunction with scalp blocks or?
Yep. Yes, it is.
So, Dr. Vernick, I wanted to ask about positioning in these cases. You mentioned obviously some lateral, quite a bit of lateral positioning, perhaps some supine. Do you encounter a lot of prone positioning for these or semi-prone?
No, I've never done one. I don't think I'd be comfortable doing an awake craniotomy prone.
So do I wonder if they even consider it, the surgeons even consider it in those cases?
I don't believe so.
Okay. And then do you find a lot of challenge with the decision-making in those patients? You describe a very collegial relationship with your surgeons, which I think probably most people who do these cases have, but when you have the strong opinion that a patient's not going to be well suited, do you find that there's a lot of contention there, or is it usually pretty smooth?
There's really only contention with one surgeon in our department.
Fair.
Everybody else is very reasonable. So if I really feel strongly, I will contact the neurology team and have them come and intervene if they think it's necessary.
And Dr. Abetta, we've seen the guidelines. You kind of described this, whereas previously it was 3 hours pretty much before you were out of the TPA window. And now we've seen that extended. We've seen the embolectomy window extended, thrombectomy window extended, even up to 24 hours in some patients. I wonder if we've reached the sort of edge of that frontier, or if you think we might see even further kind of extension.
Yeah, and so there were a few studies that were looking at extending out to 6 and even 9 hours, and they showed a positive benefit, but again, there's not enough data out there to support this. So I think there is an expanding frontier, but it's still too early.
Any other audience questions? It can be especially frustrating. We have some surgical patients who experience this intraoperatively, and then time to last known normal is obviously so vague that we lose opportunity to be too aggressive. So it would be nice to get some better clarity. Dr. Upnagel?
This is for Colleen. Do you find that you have to put nasal trumpets in your awake cranies? Or do they tolerate them? Do you tell them that they might end up with that?
I typically will place them prophylactically if the patient's obese and has sleep apnea. Otherwise, I try not to because I feel like it makes the patient somewhat uncomfortable, and it also interferes with their speech somewhat.
Oh, good point.
So, but if you need it, you need it. So if I'm doing awake, but they get a little sleepy or a little obstructive, and I'm anticipating it anyway, I'll have it in, and then I'll just hook it up to an endotracheal tube adapter and hook it to the circuit.
Thank you.
I haven't. Have you? Because we don't have it on formulary. Has anybody?
Is it in the States yet? Are people using it?
It is.
It is.
Penn has it. Yeah.
We were trying to get remimazolam for study purposes, and even that's difficult, and so.
And yes, it's extremely short-acting midazolam for those who haven't read about it. And then one other question I had, Dr. Abetta, you mentioned the assessment for conscious sedation in general, and it's fairly dogmatic, I feel like, to do all these patients awake and to struggle sometimes and convert. And it seems like your suggestion would be better assessment up front with those patients who are really good candidates for one or the other rather than convert. Am I reading that right?
Yes, the data is clear on this. You disagree on everything else, but conversion is associated with lower outcomes, and so making the decision up front and optimizing your exam helps you to make the right decision, or at least a decision that avoids that outcome.
Yes, a question over on the far side of the room. And then for our resident, at our institution, MAC means many different things, but it usually means uninstrumented general anesthesia. But I suspect in the neuro anesthesia cases, we're referring to sort of true MAC, awake and talking, just monitored. Yes.
Yeah, these stroke patients are usually come off the helicopter or picked up by staff and come straight to your IR lab. And we just last week had one come in that was on an amiodarone drip and rapid kind of AFib response situation. But everything's, we're so geared to the time to the needle, time to intervention. And he was having a large M1 stroke and a young guy in his 50s. But we kind of just kept working and kind of glossed over the cardiac issues there. And he coded in the middle of the case. So then we were doing, shocking of VFib arrest, and they still did continue to go through that. But I guess my question is there any, what's the process for your place too? Is it also straight to your IR suite with the staff, and there's really no other evaluation or workup of the patient, anything? I don't know what we could have done differently. When I look, his post, oh, by the way, his post-procedure echo, his EF was 10. Right, and so when we look back, hindsight, right, we're like, does this start off as a cardiomyopathy problem, and then it kind of just deteriorated to where we were doing stroke stuff, but.
Yeah, I find that sometimes we get too laser focused on getting to there, and there is space to take a step back and evaluate the whole patient, and even hit stop and maybe add a few minutes so that trade the cardiac exam for the neuro exam later on, which is an unfortunate trade-off, but if the patient is coding.
Yeah, but it's just so rare, right? That they
it's
come
so
in
hard.
on a pressor and for a stroke patient, right? Usually if they're generating all of that on their own. So, of course, hindsight, we're like, we should have done that or
unfortunately, I don't have.
But,
because I've run into that also, and then I look back and I'm like, what could I have done differently? And it's such a protocol where you're working with the same surgeons, you're working with the same nursing staff, and so everyone is very comfortable and communicates. And so we're very efficient, but sometimes pull the lever and stop them.
Yeah, I will say our surgeons are really great at just saying right from the start whether they want them awake or asleep, and whether they want us to put it in our line quickly or not.
Any other questions from the audience? I could talk about this for a long time, but I think I'd like to go ahead and thank our guests, Dr. Abede and Dr. Vernick, and Dr. Grenda as well. Please join me in welcoming or appreciating them. There is just a tiny bit of housekeeping, I guess. Feedback on the session when completing your attestation form at the end of the conference. Thanks, Ken. And last day of the convention tomorrow. Appreciate everyone sticking around as long as they did today. Thank you.